in this video I'm going to be talking on the retractors and the instrumentation that is necessary for performing a successful MIS TLIF procedure. Just to begin, I would like to emphasize the fact that minimally invasive spine surgery is actually a concept. And there are several, actually a multitude of retractor systems as well as instruments that are available in the market today, unlike what it was a decade ago. Virtually every company has its own minimally invasive system, both the retractor system as well as their own implant system as well. So it is basically for any beginner it is necessary to understand the concept that is underlying this minimally invasive technique. And once we understand the concept, then it is not very difficult to change or migrate from one system to the other system, because the concept or the basic principles that is involved in all these systems is virtually the same. So I'm going to discuss this under three separate headings. One is the access instruments that are required. The second one is the instruments that are required for an interbody work under decompression. And the third one is the percutaneous fixation instruments. So access instruments, as we know, the basic principle of any minimally invasive spine surgery is tubular dilatation and creating a transmuscular route to the area of pathology, and to achieve a constant or a specified diameter of a working channel through which the area or the decompression or any kind of a pathology is going to be addressed. So these varying diameters are there. So we can have 16 millimeter, 18 millimeter, which is more used for discectomy and decompression. As far as TLIF is considered, 22 millimeter is actually a standard size, where most of us use the 22 millimeter tubular retractor system. Some of us use a 20 millimeter tubular retractor system. Some of us use an expandable system, as we are going to discuss a little bit in detail. So basically, if you want to consider tubular retractors or the access systems, as we call it, so they are basically of three types. One is a fixed tubular retractor. That is, it's fixed means it's not like it's fixed and we can't move it. It is fixed diameter. So it's a tubular structure that is through and through or the same diameter from the top to the bottom, and it is this is a fixed tube. And again, several companies have come out with their own designs, and as you can see in various diagrams over here, the basic underlying common design is just it's a tubular channel through which we are going to operate. Now there are semi-expandable tubes. Basically what we mean by semi-expandable is that the outer diameter or the upper diameter, that is at the level of the skin, the tube remains constant size, whereas in the depth we can expand the depth of the tube in order to increase our area of visualization at the area of pathology or at the operative field, rather than increasing the skin incision or increasing the muscle dissection at the level of the skin incision or through the muscle. So only at the area of the operative field we can increase the visibility. So these are semi-expandable. Basically these were ideal, something called an X tube. These were ideal for single level fixations using our regular screws as well. We didn't have to use a cannulated screw in order to access the systems here. And third one is an expandable, which can be expanded both at the level of the skin as well as at the level of the depth, as well as they can be angulated to either side in order to increase the area of exposure at the depth. So again, these are basically two sleeves, 4 sleeves as well as 3 sleeves. Multiple systems are there. Again, multiple companies have come out with their own designs. Coming to the decompression instruments or a TLIF instruments, once we gain access to the area of pathology, it is important to have the good instruments to do our bony work as well as the decompression work. So if we are using a drill, it is important to have an angled attachment, because otherwise our hand may come in the way. With an angled attachment, we can easily visualize easily the bony work that is being performed, and so that our hand or the light is not obstructing our vision. If we are using an osteotome, it is better to have an osteotome with an offset angle similar to this, which is going to again prevent in a regular osteotome, the handle is going to come in the way of doing the bony work. So this is very important. Certain instruments, it's necessary that we have them as a bayoneted shaped instrument, basically the dissectors, the root retractors, the bayoneted BP handle, which is very important. Otherwise, these instruments, because it's a tubular working channel, it's a parallel working channel, otherwise our hands or the instruments may come in the way of visualization at the depth. So basically, we don't have need to have a very, very wide variety of bayoneted instruments, but actually a few of them based on individual preference and individual things. So I personally feel that at least the root retractor, one dissector, BP handle. These are the utmost essential instruments that we need to have, which are bayoneted shape. It is not necessary for a disc forceps to be bayoneted shape, because a regular disc forceps as well as a regular Kedson sponge can be used. But in certain cases, yes, a bayoneted instrument, especially when you are operating in a depth with an 8 millimeter or a 9 millimeter tube, a long bayoneted Kedson sponge or a disc forceps can be of help. For interbody preparation, of course, there are several instruments that are available. As you can see, all these instruments are similar to the ones that we use in an open TLIF case. The only difference is that these are bayoneted, so that the depth is clear, the instrument tip is clearly visible, and our handle or our hand is not going to come in the way of the preparation. And these are actually good additions to have for these in doing a good interbody work as well as a good decompression while performing a TLIF procedure. Coming to percutaneous pedicle fixation, actually these are the simplest ones. The concept and basic principles of pedicle access, as I've already mentioned, are the same for all the systems. What is different in each system is the extender tower design that is there, and the rod introduction mechanism that is actually different for each of these different systems. Again, the basics of pedicle access, which is virtually the most important step for a pedicle screw fixation. These steps are the same, and these are going to be covered in good detail later on by some of my friends. And then once the pedicle access is achieved, again, the basic principles of tapping, handling the guide wire, preventing guide wire migration, guide wire breakage, guide wire bending, all these principles are again the similar for each and every system. What is different is the extended tower and the rod introduction mechanism, which is basically different for different systems. The extended towers can actually be a sleeve like mechanism. They can actually be a reduction mechanism, or they can be a fixed extender towers with a fixed rod entry mechanism that is there. Again, the rod entry mechanism can be different. There are basically three different types. One is an arc based entry, where you have a fixed track through which the rod goes into place and gets engaged to the screw heads, as you can see here. So in these cases, as you can see by the mathematical principle, there is a fixed angle rod. The rods always have to be lordotic. These cannot be used in a kyphotic spine. These cannot be used for for a lateral bend. Introduce a lateral bend and then pass the rod over there. So then this can be used only for 1 or 2 levels. Actually, for longer levels, they're not very ideal. So there are certain systems for 1 or 2 levels where the rod goes through the extender assembly itself, that prevents an additionally separate incision. And again, these are good introduction mechanisms for 1 level or 2 level. When we are dealing with more than 1 level, 2 level, or when we are dealing with a kyphotic rod, or when we have to introduce a lateral curve to the rod, especially in cases of some deformities. So it's always better to have a free handheld entry with a caudal or a cranial incision. Most often it's a cranial rod entry incision, and with a separate incision, these rods can go in and can navigate or can engage into multiple screw holes, the screw extender towers that are there, the gaps that are there, and then reduction can be achieved by turning the sleeves. Again, the mechanism is different in different systems over here. So I'm sure that many of these systems are actually, inside the operation theater, there will be people who will be able to help you as far as when you are using these specific systems. There are flexible towers. These are actually a very good innovation, but somehow it is not very much into practice, especially in our country. There are some disadvantages to this, but the advantage is that these are very flexible. The same extender towers are not going to come in the way of doing a decompression even after screw entry point, whereas in the other rigid extender towers, once we put in the towers, then we can't effectively do any kind of a decompression work through the same incision. So to summarize, it is important to understand the concept again, which will help us to adapt to any new instrument system or a retractor design, and the basic principles of minimally invasive spine surgery, that is CDL dilatation, to reorient our anatomy to a parallel working channel for a lateral to medial approach or a lateral to medial visualization, and to reorient our anatomical structures into a circular or an oval working channel. So these are very important as far as minimally invasive TLIF is concerned, and there are a wide range of systems and designs to choose from as far as minimally invasive spine surgery goes. Thank you.